Okay, there we go. Good. Like that. Here, okay. So today, this is one of my favorite lectures, actually. This is applications of CT. And pair of decent glasses. So are there any questions at this moment anyone needs to bring up, or good, can just, oh, you know what we should do first though is let's go back to the course. Here we are here. So we have homework 4, right, is coming up. These are homeworks. I think this one is due, right? Yeah, homework 4. So I might run through a couple of examples of how this is all supposed to go, because it could be confusing. So there's a file which is, this is an example image. You know, it's a TIFF file, but it's just, we'll see it in a second. And then there's a MATLAB function, and this is the function here that you can download. It's radon transform versus sampling. And is it, yeah, okay, actually we can change that to 23. And so there's with all of these functions like the ones I given you before, you can just run the whole thing and it will clear everything, close all the figures that exist, and then just run again, right to the end. So it's pretty simple. And here you can run this program such that it can make one of 3 images. One image is a set of small squares, one is the Shep-Logan phantom, and one is this example coronary image that you download from the class canvas page. So let's look at the small squares one. So to run everything, I just, on my Mac anyway, I hit Command Return and just runs the whole program. And so what this shows is our example image, all right? And I try and label a figure so that you see what's happening here. And then this is the GL theta function for our sampling. And then this is the resultant image from this sampling. Okay, this is GL theta, the inverse iRadon transform of this data to get an estimate of the picture. And then in this window, it gives the parameters of the sampling. So here we took a projection every 10 degrees. Delta theta was 10 degrees, and we did our projection 0 through 180. So we can examine what happens when you change that sampling. So this is all just loading in different pictures. And then we come down here, this is the adjustable section that you can change. So we're going from 0 to 180. Let's instead of doing every 10 degrees, we'll do every 1 degree. So now we have like 180 projections, and we'll just hit Command Return, run that again. We'll clear the old figures. We have new figures now. Original image. This is the GL theta from that picture. And then we subsample this and create a new image here. Okay, so we can zoom in here with this little box here, and we'll look and see what's the detail here. So it's 26 to 30. So this is a 4, is that 4? Yeah, 4 by 4 pixels here. And it looks like there's a gap of maybe 1 pixel right there, and then 4 by 4 again. So that's that thing right at the top there. So if we're going to look at, say, resolution, we could ask the question like, can you resolve this gap, you know, between these boxes? Obviously, this is an idealized object in that it comes in the shape of a, you know, pixelized image. Most objects aren't like this, but for just playing around, it's okay. And then this shows the sinogram for this data. And we took 180 angles at 1 degree steps. So I have 180 points in this direction. And then it looks like I have 360 maybe in this direction over here, which is our position along the detector, right? And, you know, we can zoom up and take a look at some of these trajectories at where it's crossing over here, you know, so this box, or set of boxes, is crossing over this one at this point. Right. And then here's the reconstruction using the inverse radon transform, okay, of the picture. So this is the underlying theoretical object that produces this, and then we do the inverse and we get this. Okay, so it blurs it a bit. Now, what we can do is we can look at this structure as we change our sampling, right? So let's perhaps change our sampling. Let's see what happens if we go from 0 to 90. Say we do 1 degree projections, but only halfway round, right? So now we have our original object. We have only half of the sinogram here. It gets cut off here. And then we're going to do an inverse radon transform based on half the sinogram. And this is the data that results, or the image estimation that results. When we look at our object, it looks something like that. Okay. So you can play around with different subsampling schemes, right? Say, well, if I want to do half, perhaps it's not a good idea to just take half of the data from 0 to 180. I want projections all the way around from 0 to 180. In order to cut it in half, we'll do it every 2 degrees, right? And then we'll still go 0 to 180, and we'll run that. And so now I have bigger steps between my angles, so I've only got 90 of them. However, I've gone all the way around from 0 to 180. And if I zoom in and see what's the, you know, I basically it didn't seem to suffer much, right? From taking one every 2 degrees, right? So that's the purpose of this, is to give you a very simple function that you can play around with these sampling schemes. And so the square boxes are there to sort of look at measuring resolution as a, like, you know, the grayscale between the boxes. Let's turn on. This Shep-Logan Phantom comes with MATLAB. I guess you guys, I don't know if you guys have used it yet. But here's the original Shep-Logan Phantom. It has certain, you know, contrast levels in it and a certain geometry. Everything in this Phantom is an ellipse, basically. So you can actually write down the analytical form of this sinogram if you want. And then, so this is the sinogram with projections every 2 degrees. And that here's the image that results. So you can see there's some complex artifactual stuff in the background due to the fact that we don't have high enough sampling rate, you know. So let's change it. Let's go back to 1 degree. And so here in the background now, we've fixed a lot of that sampling, but there's still, you know, off these really sharp edges here, you still see some streaks coming down. And that's due to the fact that, you know, the projection between the 2 angles at this vertical view, you know, doesn't sample this edge highly enough. What happens if let's try, let's go to 0.5, see if, right now we got lots of projections. We have 360 of them. Yeah, that stuff goes away, right? So there was something about the undersampling of this very hard edge at only a 1 degree difference between the projections that caused this basically streak in the background. And you can look at the details back here. You know, that compared with what is the actual edge. it looks like that. Yeah. So there's still some blurring on there. If we load up the CTA image, so let's turn that one off, turn this one on, see what happens. Okay, so this is the picture, sinogram of the picture, and then the inverse of this, the radon transform of this, giving us that. And so you could look at the difference between these two pictures, perhaps, to analyze the change in features and image quality as we change these settings. And so what happens if we say, well, we want to do this with half the radiation, so we'll change, well, let's say a quarter of the radiation of that one, we'll change this to 2, right? And it's still a very reasonable picture, right? It does have a lot of this sort of underlying streaking noise structure. It's not really noise, it's an artifact as opposed to noise, which, if the original image itself, if the original data itself had a lot more noise on it, then these streaks probably would also amplify that noise. And what happens if we go to 0.25? I don't know if it'll run. This takes a long time now. Yeah. And now probably if you take the difference between these two, there probably isn't much of a difference anymore. Okay. I think there's a section in the code down here. There are some missing contiguous data segments to try other techniques. And so here, I just said, well, I'll try deleting some data and see, what the outcome is for the image. If for whatever reason you're missing views, and this could be, for instance, if you had something happen during the acquisition, like the patient, as halfway through the acquisition, hiccuped or something like that. And so you say, well, what happens if I just get rid of those views that are corrupted? What's the resulting outcome for the image? And that's down here. So you can just play around with that stuff. Okay. So any questions about that? You don't even really have to know MATLAB to run this. You can kind of, anything about programming in your past, you can just change some of these numbers and everything will run. And those of you who want to be more sophisticated with changing sampling protocols could try that as well. Okay. And then I think resolution is this. Okay, so that's the first part. And then the second part, we're going to look at the resolution. You've already done this on, I think, problem set 1. You looked at the modulation transfer function by measuring the contrast between these circles as they get closer together, right? And when we did that, I believe this phantom was sitting in a configuration such that this would be the X direction, this would be the Y direction. That is, if we're looking into the bore of the scanner, you would see this picture. If a patient was lying on the table, their left arm would be here and their right arm would be here. That's on homework 1. What I did with this one was I rotated this phantom 90 degrees such that this is now in the slice direction. Okay, so the question is, what is the resolution now when we're looking along Z? And in this scanner, remember, it has about 1,000 elements in one direction, and then in the slice direction has 256 elements. So if you just take a fixed picture, is the modulation transfer function in Z the same as you had measured in X and Y, is the question there. Okay, and then I think these were the distances between those drilled holes. So you don't have to measure these again. This is the true difference. And then this gives you the line pairs per centimeter for plotting the MTF. This phantom, it turns out, took a long time to make. There's a very good machine shop in mechanical engineering here on campus. And the machinist who did this, it was fantastic. To get down to these really tiny holes into plastic, it's really hard, right? You know, you would think, well, I just drill a hole. Nope, you've got a drill bit that is very, very delicate. And like, how do you get these holes to happen at that diameter? And so it took a while. It was really expensive to make this phantom, but it's great phantom for resolution. Okay, so that's the geometry of that question. And I think that should be pretty clear. Okay. Any questions out there? If not, we can get started here. Okay. So I think we looked at this a little bit not on Monday, but last Wednesday, where we were looking at coronary CTA, or coronary cardiac computed tomography, where the diameter of a vessel such as this, of a coronary artery, which is about, say, 4 millimeters up towards the aorta, the proximal part, gets narrowed down by some kind of lesion. And in this case, the lesion also has a little chunk of calcium in it. And so this is why we need high resolution pictures, right? And why we're pushing image quality into high resolution pictures. And obviously, we need motion correction when we're looking at pixels that are on the order of, you know, 1/4 millimeter, because holding the body still to that threshold is really hard. And so we looked at this and we said, oh, okay, you can see the proximal diameter of this artery in the fat bed here. You can see the lesion and still the diameter of the artery where the lesion is. And one would say that flow is not going to be perturbed by this lesion, right? Because it's still, you've got a wide open artery here. So you're not going to do anything with this person. However, downstream here, there's a little bit of a stenosis. We also looked at the use of coronary calcium to predict somebody's risk for having a heart attack or some kind of major cardiac event in the next 10 years. And coronary calcium and the amount of coronary calcium is the best predictor right now of any analytical test, any blood test, any blood pressure test, any clinical score, anything like that. And the best predictor by a long shot, right? So they all pile up here on the ROC curve. And we'll review what an ROC curve I think is in a minute. But coronary calcium has just shown over and over to be the best thing to do. So if you're giving your parents advice on what to do in terms of cardiac risk and whether they should go on a statin, they should probably get a CAT scan because it's really cheap and very predictive. Then we looked at this company HeartFlow that created a technique for calculating the fractional flow reserve with CT data by cutting out an anatomical model of the coronary arteries, looking at the anatomical model of the downstream muscle, and that's like the volume of blood required to go through these arteries, running a large computational fluid dynamic simulation to get the blood flow as a function in these arteries, and then measuring essentially the pressure drop as we go down an artery. And so this is the predicted fractional flow reserve you would measure if you put this patient in coronary cath lab and you did FFR with a wire, with a pressure wire. It turns out they're very good at doing this now, and they're quite accurate. And this technology has been adopted principally because insurance companies are interested in keeping people out of the cath lab who don't need to go into the cath lab. If I'm an insurer and I have a patient who, has intermediate chest pain and whatnot, if I put them in the cath lab, that's an expensive proposition, right? It's an expensive test. Possibly if you have an aggressive cardiologist who likes to put stents in, you might wind up with a stent. And so the whole thing's pretty costly. If you can use FFRCT to keep people out of the cath lab, to say, look, yes, there's a lesion here, but it does not reach the threshold, right? If you go to the cath lab, when they do FFR, you will not have a value that's below 0.8, then it's a win for everybody. It's a win for the patient, and it's a win for the people looking after that patient, Medicare or the insured. And so this company, basically, that was the outcome from their trials. They spent, their second round of funding was 250 million. I think their third was 400 or something. So they had a lot of resources and they did really large trials. And essentially that's the conclusion everyone came to. And it's now standard of care almost. So this is a great story in terms of getting a technology into the American healthcare system. It took a lot of money. It took a lot of work to shop this around to every insurance company and say, hey, you should cover this because it's in everybody's interest. So anyway, that's available now at virtually every large medical center. So today, other applications we'll look at is phenotypes, or the analysis of coronary lesions based on their structure or their phenotype, their morphology. We'll look at some of the issues with measuring perfusion with CT, and we'll look at some of the issues with measuring function. That is, how does the myocardium contract? Is it contracting normally? Is it contracting less than normally? And then a bit on procedure planning. So CT is a fantastic imaging modality if you're planning to put, say, an aortic valve in a person and you want to see the exact geometry of their existing valve. If you have a left ventricular assist device and you want to see what's the state of the heart at this point, and we'll see also the left atrial appendage, which undergoes some interventions. So the first thing, let's review, because I couldn't remember whether we did this. When we go back and look at the effectiveness of a diagnostic test, right, you come up with a number, and in this case, it's the coronary calcium load of this patient. This patient has 0, 100, 400, and you use that number to make a decision. So you say, well, if anybody is over 100, we're going to call them positive. We're going to say we predict they will have a heart attack. 80% of the people that do have heart attacks, you will predict correctly. However, you will also tell about 35% of the people that will not have heart attacks that they probably will have a heart attack. So that's this ROC curve. How does this thing come about? It's from this. So if I have a distribution of patients, this is my decision parameter. In the example we just gave, it was a simple number. It was coronary artery calcium, right? So it's just a scalar number. You can obviously make a scalar number out of lots of things. Their genetics, the summation of a whole bunch of clinical parameters, et cetera, to get a decision number. And then you plot all of the people that are quote unquote normal, or in the case of predicting heart attacks, people that don't go on to have a heart attack. And then you can plot a histogram of that decision parameter in people that do go on to have a heart attack, or the abnormal population. Independent of where you decide your threshold is. If we say everybody above 50, we're going to call abnormal, that means we're going to get this number of people that are false positives. They're not going to have a heart attack, but we're going to tell them they probably will. So obviously the best thing to have is this histogram, You know, if you look at the histogram and you're a clinician trying to figure things out, you can get the person's parameter and you can look at the histogram and say, well, you got a 50-50 chance probably of being normal or abnormal, right? The way to put this on a chart is you say, okay, I'll move the threshold, right? Let's move the threshold such that everybody who is above T, we're going to call abnormal. So if I start with my threshold down here, right? So it's a really low value. And I say, I'll call everybody above this threshold abnormal. Well, then when my true positive fraction will be 100% because I'm going to get everybody. But I will also include the entire normal population in that number. So I have a point up here. That's my operating point if my threshold's here. As I move my threshold such that I am more selective. So I say, look, you have to reach a value that is at least this high to be called abnormal. What happens is I move down this curve. Okay, so I get to this point where so I'm at 70%. I'll pick up 70% of the abnormals and I'll only pick up 30% of the normals. And so this curve, as we move T along here, we derive this receiver operating characteristic curve. And the best ROC curve you can have is if these two underlying distributions are completely separate. And therefore there is a T in which you're sitting at this point. You get 100% of the abnormals and you get none of the normals. In order for that to happen, these two curves must be completely separate. And that never happens in medicine or biology or virtually anything. Virtually anything that's interesting, like poker and all these gambling things, it's like, what's the odds that I'm going to win? So generating a curve that moves as far to this left corner as possible is essentially the quality metric that we would like to optimize our imaging on. We would like to run some optimization. Say we say, I'm going to change the energy of my X-rays in my coronary artery images and see how that affects my ability to predict people having a heart attack. I can run through energies, and what I would optimize on is the best ROC curve. And so oftentimes that's the area in here, right? Which is somewhere between 0 and a half, right? So this area here would be a half, right? So that's normally what you optimize on. So this is a good thing to know. Specificity, is the true negatives over all of the negatives, and the sensitivity is the true positives over all of the positives. And there's a couple of other things like positive predictive value and negative predictive value that are also useful that you can derive from this curve. Okay, the ability with CTA, and this has been established for the last 15 years, is that if you go in and you have a test and they take a coronary angiogram with a CT and it looks like this, right? You're virtually 100% confident that you are not positive, that you do not have coronary disease. It is very hard to make a beautiful image when the underlying pathology is there. Okay. The opposite side of that is it possible to make an image that looks like there's a lesion there when there isn't one? And yes, there is that possibility. For instance, motion might screw up your signal such that it looks like there's a lesion. However, if you get a negative call, you are, super likely to be negative. It's like 99% or something. So as a decision point, if you're somebody who has chest pain, intermittent chest pain, and you go to the hospital, and the question is, should you be worked up for cardiac disease, for coronary disease? Should you get on the treadmill? Should they check you in overnight and take your ECG for 24 hours, et cetera, and do a stress test? If the first thing you do when you walk in the door is you have a CTA and it's negative, you can just go home, right? Take some Rolaids because you've got indigestion or something and go home. And so in Europe, that's what they do now, right? Every person that has chest pain, they do not work them up for heart disease. They just take a CT, and then basically 75% of the people get sent home, right? That is not the case here. That's not done here. And so this was from the National Health Service in Britain. They decided this was the course they were going to take, given all the data. And they subsequently started to purchase a ton of CT scanners and try and train up physicians to read them because they had a lot more cases, right? So now when we look at, say, this person who comes in and has intermittent chest pain, and we see this image, right? We look and go, oh, okay, well, that thing there sure looks like a lesion, right? On the CT. It looks like this gets narrow here. It looks like there's possibly soft plaque there, but that could be fat, right? And so you would call this positive. The problem with CTA up to this point is maybe half the time when that happened, this person would go to the cath lab and it would not be positive, right? And so that was the fundamental issue with CT. It called too many people positive, and therefore, and this is ironic, too many people got sent to the cath lab. The reason cardiologists did not want CT in their pathway was because they feared it would be a gateway to the cath lab, or basically not a gateway, a gatekeeper to the cath lab, and patients wouldn't get to the cath lab. Their business would go away. The exact opposite happened. When you start putting CT in the front door, all of a sudden the cath lab business doubled because many more people were called positive on the CT and wound up in the cath lab. And so that kind of one of those ironies, you know. However, with the new FFRCT that is done, that problem is diminished by a significant amount. And I think it's due to the fact that the company that has the FFRCT algorithm also has hundreds of thousands of CTAs, knows the outcomes from cath, has trained deep learning segmentation tools to look at these arteries, and it's that's going on. It's not computational fluid dynamics anymore. It's the deep learning segmenter is looking at it and going, yeah, this is a significant lesion, and it's getting right. It's getting it right way more than people. On an X-ray angiogram, this is a significant lesion. So it's like a more than 50% reduction in diameter from here to here. And then if you go distal, it gets bigger again. So this thing here should be at least this big, and it's not, right? And so that would be called positive. The other interesting thing about CT is that unlike X-ray angiography, in CT, you can kind of, or not kind of, you can exactly see the components of the lesion, right? If the image quality is high enough, you will be able to look at different components of these lesions. They're not all built the same, right? So let's look at this. So here, this is, you know, plaque type across here. And this is called soft plaque. It's called a PR soft plaque, or positive remodeled, because you can see the plaque lifts off the outside of the vessel. And so it's a bulge on not just the inside of the vessel, it doesn't come in here, but it goes to the outside of the vessel. So it doesn't reduce the diameter as much, but it shows that there's a large plaque there. So it's sort of the plaque burden that you're counting up. So that's called a soft plaque because it doesn't have calcium in it, and it's positive positively remodeled. Here's a plaque that also is positively remodeled in the sense that this vessel gets a lot wider on the outside. It does have a small piece of calcium in it. And then this is basically a heavily calcified coronary lesion. This also can be the Achilles heel, let's say, of coronary CTA. If it is so heavily calcified that you can't see any detail inside that vessel in terms of, is there blood flowing through a channel in this heavily calcified tunnel? The blood has this signal amplitude. The calcium has a signal amplitude that's 3x that or more, right? Or 5x that. So this is super bright, and you're looking for a channel in here that is of this amplitude. That's hard, because if there's any blurring of this very large signal, it will lift up the signal inside the channel. It'll be hard to see inside that channel. So I would say one of the unsolved problems in coronary CTA is, how do you create a CTA image that is only representing the contrast filled blood and the calcium gets deleted, right? So ideally you would delete this calcium signal and see how much blood remains. When you take the patient to the X-ray angiography lab and they inject contrast in this vessel, X-ray angiography is not that sensitive to calcium, not as much as CTA. And so they will see, a pathway through this lesion in the angio suite.
So the issue is that the calcium on the outside can block the signal, so you have no idea how powerful it is.
Yeah. So the comment was, so the calcium on the outside of the lumen it has such a high amplitude that you block your vision of the lumen because of the interference of this calcium. And that is correct. That's one of the troubling things about CTA. This is obviously most troubling for people who are above, say, 65 years old, because you accumulate calcium in your vessels as you get older. So if you have a patient who's like 77 and you're going to do a coronary, the probability of getting a really good result from coronary CTA or coronary CTA starts to go down if they're really old, because the probability they have a lot of calcium goes up. So here's an example of heavy calcium, right? As seen not along the vessel, but in a cut that is axial to the vessel. But you can still see at this point, we have enough lumen here. We don't have a problem, right? We know that is okay. This is, you basically have calcium here, and then you have some soft plaque between the calcium and the lumen. And so it's called low attenuation plaque, which, now this is tricky. If you go down here and you say, well, this Hounsfield unit looks like fat. It's not even muscle. Like, it's not basically the arterial wall or inflamed arterial wall. It's less than that. The Hounsfield units are down around minus 150 or something. Then that is fat, probably. And if you can visualize the whole lesion such that you see the lipid core of the lesion, and this, in pathology and stuff, you cut these lesions open, they do have this pocket sometimes of lipid inside them. That is a sign of a lesion that has higher probability of rupturing and causing you a major heart attack. So this low attenuation plaque is a significant sign for risk. And here we have positive remodeling on this. Here's the lumen here. You've got low attenuation plaque and you've got calcium. So this thing's got everything going, right? This lesion. This is another type in terms of plaque pattern. Here's the lumen down here, right? And then as we move towards into the plaque itself, we have, this is called a napkin ring sign because of the shape of it. This has low attenuation plaque in this, with this curve around it like that, and the lumen right here, very close to that low attenuation plaque. You know, if you squint, you say, oh, okay, I believe that, that's low attenuation plaque there. But again, we would really like resolution about another 3x at least to visualize this with great certainty. But this napkin ring sign has been found to be a very risky thing to have, and that's low attenuation plaque really close to the lumen, right? Okay. And then look at this is spotty calcium. So these are tiny little flecks of calcium in the vessel, and it's saying any calcium below 3 millimeters versus chunks of calcium that are laid down as big planks, you know, in the vessel. Spotty calcium, when it has this feature, like lots of little bits of calcium, again, that has been associated with higher risk, although that has been called into question on a couple of recent papers. But so there's a whole rogues gallery of pictures, you know, to essentially classify these plaques. And some of the early adopters of coronary CTA who ran research programs that built up, you know, databases of thousands and thousands of patients, and now those outcomes of those patients are known. They've started companies that are using deep learning and artificial intelligence, machine learning, et cetera, to try and characterize these lesions and the risk. So come up with a risk score that basically looks at these features. And so you can look at the individual risk increase given a specific feature, right? And so if your stenosis is high, so basically the diameter reduces by greater than 50%, the probability of having an acute coronary event in the next 10 years, we'll say, goes up over the baseline by a factor of 34. Right? So this is fairly predictive of, you know, a future event, right? This positive remodeling here. So I have a soft plaque. I do have a narrowing, but this narrowing looks like it's, you know, it might not even reach 50%. But this fact that this thing bulges out here still gives you a relative risk that's quite high to baseline. Low Hounsfield unit in the plaque. So here, they measured Hounsfield numbers that are down in the fat as opposed to what it is in the muscle. That gives you a relative risk increase. These, I think, are all independent. They're not normalized out for the other risk. That's in a multi-part model. Napkin ring sign, here's our low Hounsfield unit right next to the lumen. That also has risk, and spotty calcium has a risk. Now these are from 2014. So this data will just get better as these pictures just get better, right? As coronary CTAs become more common and there is more data available, and as the machines themselves, you know, as photon counting machines come online, these pictures are going to get better, but that's sort of a decade away to have a lot of photon counting machines available. Okay. And so here's I've put the paper down here. You're welcome to go and read it yourself, but here are the relative risk increases given these essentially morphological or, you know, risk plaque features. So you could build a classifier that, you know, looks at these features and decides what the thing is to measure. So reasons for poor image quality, you know, when you have these studies where they've got thousands of coronary segments. So in this, they had 7,000 coronary segments that they're evaluating. When they looked at the picture and they saw a lesion and said, you know what, we can't tell you the details of this lesion. There wasn't that many in this data set, right? There's 200 out of 7,000. But, you know, there was in 71 of the, 15% of the patients, they had at least one segment that was not valuable, they couldn't evaluate. Perhaps there were other lesions in that patient, so it didn't matter. I mean, your risk is sort of, but motion artifacts were the primary cause of this problem. Okay, so one of the issues is if the heart rate back, and this is data from 2014, right? So these images were obtained probably from 2005 to 2012 or something like that. Scanners were not as good back then. The gantry did not rotate as fast. So it was absolutely essential that the breath holding was perfect and that the heart got into a quiescent phase. So normally it's end diastolic, resting state is when you take this picture. Some patients, if their heart rate's too high, they don't have an end diastolic state that is that long. So I would imagine in most of these, they put them on a drug that lowered their heart rate. And so you get the heart rate down to 65, and in these old scanners, you get good pictures. But motion artifacts are always going to be a problem because we're always going to be increasing the spatial resolution. So if you double your spatial resolution, your motion artifact has to be twice as good, right? Because, now we're into really small motions causing motion artifacts. And we looked at what dose does to image quality. And if all you're interested in measuring is, say, the ejection fraction of a heart, so you just want to look at how much blood is in the left ventricle at end diastole and then how much is it end systole and get an ejection fraction, you could use a picture like this. And this has 1/10 the radiation dose of this picture, right? This picture, obviously, like image quality just goes up nicely with dose, right? So if you have a lot of photon flux, you're going to have some really nice pictures. And what happens, it's not just a signal to noise issue, right? What happens when you go to these lower doses is that in order to create a picture that doesn't have crazy artifacts in it, you need to look at your raw data and smooth it out. And when that happens, your spatial resolution goes down, right? And so it's not just a signal to noise issue, it's a resolution issue. And every scanner that you can buy commercially, if you start dropping the dose, it will start ramping up the preconditioning of the data such that the image you get is blurry. And so you can put an ROI on it and say, what's my signal to noise, in the left ventricle. So if I put a circle here, right, and measured my signal to noise ratio of the blood to the background, it does not go down as quickly as you would expect when you drop dose. And the reason it does not is the manufacturer does not let it. They smooth that data so that basically the signal to noise ratio stays as constant as possible. So unlike MR and other places where all of this is pretty simple, in CT, you have to be careful. You can't just measure signal to noise as your only image quality factor. It doesn't work, okay? You can see that here when we have a feature in this image at 700 MA and 70 MA, and you look at the background and it's not just noise that's the difference between those two pictures. Specifically for things that have really sharp edges, there's a big difference, right? So it's just a smooth picture. So there's the difference. It just goes, the details go away, right? So it's not just a signal to noise thing.
I've heard of micro CT,
Yeah.
but what is that?
Okay, so the question is, what is micro CT? So micro CT is a scanner within which you can image something like a mouse brain or a mouse heart. And so the question is, how would you do that? You know, and it's pretty cool. Let's say we have a mouse and we put it on a little table, and we have an X-ray source relatively close to the mouse, right? And then we project that X-ray through the mouse and magnify, you know, as you move away from the mouse, it gets magnified, right? The shadow gets magnified, and then we detect it on a big digital X-ray detector. Okay, and now I rotate the mouse. Okay, so if I rotate the mouse, then I've got a whole bunch of projections, and basically the spatial resolution of those projections is very high.
It's high because why?
Well, because we have a X-ray source that has a tiny spot size. It could be something used for mammography, for example. And I project the shadow up to a large detector. So my geometry is such that I've been able to magnify the image itself, right?
Okay, and that's not a scalable concept, so like a full size TV?
It's not scalable to a full-size CT in the sense that the geometry of a full-size CT is kind of fixed with a meter-wide bore. If you wanted to do that, you would need a much larger bore, and your source has to be close to the sample, so it would be sort of an asymmetric thing. You could, I mean, one thing you can do is you could put a person standing somewhere.
Oh, you know, like those carnivore rides where you
Yeah.
stand up against the mat?
Well, not that. You just put a person on a you know, a platform that spins. Okay. And if you put a person on a platform that spins and you put an X-ray source right next to them and shine a shadow on a wall that's, say, 3 meters, 4 meters away, now that picture of them on the wall is quite large, right? And so you get a high resolution picture, and then you rotate the person, right? So that's another way of doing it.
Maybe put that into a carnivore ride. Maybe you get less anxiety with the imaging process.
Well, sort of, except you have to spin the person, right? And if you spin it at the same rate that modern CT scanners go, they're rotating at 4 hertz, and so they're like they're not happy at that point. But you can, so Siemens builds these X-ray angiography systems that have a C-arm, so it has a detector on one side of the C-arm and an X-ray source on the other, and it is attached at the middle of the C-arm to a KUKA robot. Okay, so you can program that robot to essentially move that C-arm through arbitrary angles. And so you can, the example I just gave, you could just get the C-arm to go around a patient who's lying on a table, right? And that is a product. You can do that, right? That's called cone beam CT, right? That's pretty cool. So, but micro CT, usually it's something that's kind of the size of a Volkswagen Beetle, and and it's a system that you put a mouse or something like that in, and it gives you an image that's usually the voxels are on the order of 50 microns on a side, something like that.
Because I was wondering if they have like access to some like special kind of detectors that
Nope.
scale to.
No, I think it's just the geometry of the scanner. Most of the technology is off the shelf usually, right? And yeah, but we've used them for if we have a small phantom that we image in our clinical scanner, and you want the underlying truth of the dimensions of the object, you can put that into essentially a ultra resolution CT scanner and get that underlying truth, right? By a factor of 10 or something. Okay, so here's an example of coronary arteries. Okay, so these are This is the right coronary artery here, and this is a branch of it by the look of it. And these are images obtained at different phases of the heart cycle, right? And so you can see that there's two phases at which the coherence of those arteries is intact now, and that's end diastole, because you can see the heart relaxes and the blood fills into the left ventricle, and then it sits there for, say, 200 milliseconds, and it's 250 maybe, where you get a good picture. And then end systole is when the heart is contracted maximally, and so the left ventricle is the smallest it's going to get. And there's about a 50 millisecond window there where the heart's still. And so there's a lot of coherence in those vessels at that point, right? Anywhere else in that heart cycle, and you can see they're a mess, right? There's this basically cycloid kind of pattern, and very difficult to read. In fact, radiologists won't read them. They'll just like hand it back and say, nope, can't read this. So ideally, you just fix the motion artifact. You reconstruct, including in your reconstruction an estimate of the motion, and you iteratively reconstruct until you get a good picture. You can make CTs of moving objects, and it's obvious you can, because in the frame of reference of a CT scanner, the patient is spinning at 4 hertz, right? So the patient is moving like crazy in a circle, but in a very prescribed way. So you just have to get the prescription right for the thing you're trying to reconstruct. So here's an example of a right coronary artery in this patient, and we're trying to look at, whether or not it's open or its diameter or whatever. And this is uncorrected data, and this is motion corrected data. And this is a project we did with GE. We had a way we wanted to motion correct, mostly to motion correct the myocardial motion, but it turns out obviously that it's correcting the coronary motion as well. And they also had a product that worked. No, I don't want the pen. Sorry. How do I get back to my? How do I get off that thing? Here we go. Okay. We can look at individual frames here. And as we go through, you can see the coronary itself is essentially not visible in the uncorrected picture. There's a big dark hole here that's like a negative signal, where the coronary sort of left this area, right? Whereas in the corrected data, you have a coherent coronary signal at almost every phase, right, of this. So here it's in some kind of cycloid shape here. Here it's taken that into account and mapped it into its correct location. So in this case, so here the coronary itself is stationary for a little while, so you get a good picture. Here, you get a good picture because you corrected it if there was motion anyway.
So did you do this algorithmically with just the raw data, or did you have to track some other thing to track the motion?
So the question is, for this motion correction, do you do it by looking at the raw data and modifying raw data to include, so you would modify the data to assume that it's moving, right? And you can do it that way. The way this works, it's called, this algorithm is very similar to an algorithm called, or it is in most aspects, an algorithm called snapshot freeze. And you can look that up, and it's a really cool algorithm. We wrote a very detailed paper on it in medical physics. And it essentially takes reconstructed images at 3 time points, and it looks at what changed between the middle time point and the one in forward in time, and the middle time point and the one backward in time. And it uses that to estimate a motion field and then make the corrections. right? And then remap pixels, right? Now, if in a patient you are lucky enough to hit one of these phases where there is, the heart is being held still, then you don't need motion correction to get this. You just need a lot of reconstructions to find the one that's correct. And that's essentially the way it's done clinically for a lot of these, is even when you have motion correction on board, they still reconstruct a lot of phases to find the one that's the right one. And then here you can see that there's another phase where it looks like it's pretty coherent, but then it takes off again. And then even when it's really moving fast, this algorithm fails, right? You can see here it's failed here because the motion is beyond what can be corrected. Okay, so that's a big application. It's on every scanner now, though, this motion correction stuff. What we'll move on now to look at perfusion with cardiac CT. And so if you want to look at, is blood flow going to the myocardium, right, everywhere? Or given this poor state of affairs with these coronaries, you can see how much calcium is on these coronary arteries here. This is a case where trying to read this for stenosis is impossible because it's just covered in coronary calcium. So it's almost like it's inside a shield. However, if you image over time, it doesn't look like that's going to play, but I'll show you one in a minute, where you watch the contrast go to the right ventricle, then the left ventricle, then the myocardium, and you measure how the myocardium gets brighter, then you can get an estimate of the flow. And so if you look at these are the Hounsfield units, they're going up to 600. So these are the Hounsfield units in probably the left ventricle. And then over time, as we take these images, it looks like every third beat, right here, we measure the increase in the signal and then its decay. And you make that measure in the myocardium as well, right? And you can get a map of essentially relative flow in the myocardium from that. This is obviously taken from a YouTube demo. And so now you would get a map of a perfusion deficit in this left ventricle, okay? I'm running out of coffee, okay. Here is the arterial signal. So we go up to a very high Hounsfield unit here, right? And then the tissue, the underlying myocardial tissue, it tracks with the input from either the aorta, and it hits a maximum and then decays away. And so you can model the amount of flow given this green curve here and make that map here such that you can detect whether or not you have a significant flow deficit. This has been studied extensively by a few groups with modern CT technology, and we've done it a lot. My conclusion is that it's really hard to do, right? So this works a certain percentage of the time. A certain percentage of the time, it just doesn't work very well. And I can't give you an explanation of why, right? There's a number of factors that are involved, but it's not a simple reason why it doesn't work all the time. But we can, I'm gonna skip ahead. One thing is, if you look at the signal, so when you look at a CT scan that has contrast on board, the signal in the blood is really high. And so you're desensitized to any variation in the signal in the myocardium. The signal in the myocardium is what we want to measure perfusion, right? And so that's the stuff we want to look at. So if we look at it in particular, forget about this. This is so high, we're not going to look at it anymore. We're going to look at the signal in the myocardium. You can see there's a lot of variability in that signal around here that is not evident when you're looking at a dynamic range that includes the blood. And the other thing is, if you look at the dynamics of that changing signal in the myocardium, so here's a Cine acquisition through the heart cycle. It looks fairly reasonable, but now when we look at it, down at the myocardial level, you can see there's some pretty complex signal variation going on in time, right? And this is obviously dependent on where the gantry is at any phase of the heart cycle, because this artifact seems to be rotating. I mean, do people perceive that? It looks like it's rotating around with a gantry, right?
Yeah.
And so the other thing is that we're taking this image over the course of time where we assume that, in any one CT, you assume that you're imaging the same object, right? But in cardiac CT, you're not, because as the gantry moves around, the heart is also beating, right? And so you're going to start getting artifacts off of the walls that are moving because they're inconsistent, right? It's an inconsistent signal. And so we're getting a lot of this artifact. In this case, this is very exaggerated. You can push this down with some simple stuff, but the fundamental is true that the variability on the myocardial signal is quite high from the surrounding artifacts versus the amount of change from the inflow of contrast into the myocardium. So hence, it doesn't work in everybody. However, it turns out that for those of you who have read or are going to read, and I would advocate that you read that paper called about the ischemia trial, and then the subsequent analysis of imaging technologies and which imaging technology predicted downstream events in the ischemia trial. Perfusion turned out to be a really poor predictor of how people were going to do.
Perfusion
using anything, using echo, using SPECT, using MR, which if there is a winner in this perfusion battle, MR is the clear winner, right? The quality of MR perfusion is miles ahead of every other thing, except PET, right? PET perfusion is probably the gold standard. But not everybody has access to a PET scanner, right? So it's not commonly done. MR perfusion, fantastic method for perfusion. However, MR scanners are all in radiology departments, and so cardiologists don't send their patients to MR that often. But it turns out that the perfusion itself didn't really predict what was going to happen to that patient. The only thing that predicted in the group that was in this ischemia trial was plaque burden. It's like, how much plaque did this person have? Just count it up, right? And if they have a lot of lesions and it's a heavy lesion burden, that person was at much higher risk. It makes sense, right? And so it's sort of direct measurement of the thing that will kill you, right? It's the lesions will kill you, not the lack of perfusion, what I mean? So I would recommend you read those papers. They're for me, they're highly influential in what I would study over the next 10 years, right? Like what's going to be an important thing to know. And so, here's low dose CCTA. So if you do a 700 MA scan, like that, remember that really high definition scan, it was 700 MA. And you have the issue that I really want to catch the stationary point in the heart cycle. So I'm going to scan the whole R to R and I'll pick out the best point. That gives you a scan that usually in most people, that's about 4 millisieverts of radiation, right? And if you want to do it for less, you want to get down to 2, get down to below the background radiation. So that's about 3.5. You want to drop your dose. And so a lot of people have been working on how low can you go and still get good images. And it is entirely dependent on the size of the patient. That is the primary consideration. If the patient weighs 350 pounds or their BMI is like above 30 something, they're going to require a lot of x-rays to get through them, to get a shadow on the other side. If the person's a little person, then you can get away with really low dose and lower energy x-rays, because the 80 kV x-rays go through the person, right? 80 kV x-rays just don't go through a large person. They're too big. So if you have the right morphology of the patient, you can get away with something like this, where you get the whole scan done in, about a millisievert, right? And you get these fantastic images of their coronaries. You can also, if you're willing to image at 2 points in the heart cycle and get up to, in this again would be in a small person, about just under 2 millisieverts. So we're taking a picture here and here. Then you can get the heart in the end systolic configuration and the heart in the end diastolic configuration. This transformation from here to here tells you a lot about the person's health, right? If their heart's, contracting appropriately, then they're in much better condition than somebody who has, dysynchrony or a part of their heart that's knocked out. Here's what CT looks like in a movie. This is I think this is like a 1.5 millisievert movie, right, of this person, because we're down at a I think it's 120 MA or something. So for cardiac function, you can get away with really low dose, right? This is no, this is actually reasonable. This is about probably injection fraction of 50%, something like that. This person is looking okay. This person, on the other hand, Echo called this person normal. And they look normal when you look at this short axis and this short axis. And then you say, well, what the heck's going on there? What's that? Maybe that's just cutting into the outflow track or something like that, this thing here. But then when you look at the orthogonal view, there is a whole chunk of their myocardium that's like down. And so they had an infarct is what happened. This person sometime in the past had an infarct. Echo did not call this person abnormal, right?
I guess it could get infarcts in the septum.
Yeah, sure, because
What's the five?
well, it's basically, if you look at the left anterior descending, and if I look at my heart and a bullseye at 12 o'clock, I have the anterior wall, and then at 11, 10, 9 o'clock, I have the anterior septal wall. So on the anterior septal wall, that'll be the LAD or one of its side branches, right? When I get down to the posterior septal wall, it'll be either the right that's coming down the back of the heart, or it could be the circumflex, right?
Yeah, I guess I can think of this. Talk about like the outside of the heart.
Right.
But it's got to go like, deep into it.
It does, but when you look at how the left anterior descending vessel runs across, if you crack open somebody's chest and you look down at their heart, you'll see the LAD running straight down the front of their heart. Right below the LAD is the septum, right? So it puts down perforators down like this, and they go that way. Now here's a patient that it is fairly obvious, right? You don't need to be a rocket scientist to read this one and say, something's wrong here, right? Because I've got a much thinner heart wall, even at end diastole, and it's not really contracting that well. Okay, so there you have an obvious infarction, right? This person has had a previous infarction. You can look at these, which cardiologists do not, but I do. In all the cases where I'm looking at, a heart and trying to evaluate its function, I look at these movies, and you can see the relative motion of the ventricle, of the left atrial appendage. You see the relative motion of the atrium when it contracts, etc. Right? They're really powerful. And we're going to skip through this. You guys have looked at that. Ejection fraction, you get a really good set of points for the volume of the left ventricle from CT. This is plus or minus a few percent of volume. It's reproducible. Whereas in other modalities like echo and MR, these numbers have a lot of noise on them, but in CT, it's just lock solid. What you can see here is, the relative motions of all of this trabecular tissue. When you look at the inside surface of the left ventricle, it looks like this. That's a human left ventricle. That's the inside surface, right? And so it's got all of this web structure here. And on echo and on MR, you can't image that because basically the structure itself is the components are too small to image. And so they come up just as like an average change in signal. Whereas on CT, you look at this and you go, oh man, you can see them directly, right? And so you can measure how these little individual nooks and crannies are actually moving over time to calculate or to detect abnormal motion. And so here's an example of that patient, right? See this golf ball right here? It's just not moving. Those nooks and crannies are not getting any closer together. They are just getting dragged around. And this piece of tissue above this, remember, this is the blood. This is a cast of the heart. The tissue obviously above that is not contracting because it just isn't. Over here, you have sort of normal contraction. These nooks and crannies are getting pushed together. These are not. So it's a really direct way of visualizing if you have an abnormal heart. And we trained, there's one of the recent papers from the lab. I really like this paper because every time I look at function, right, I look at these things and I find these, points here that are abnormal. This is a lot of data. This is 512 by 512 by 256, 3D data times 20 time frames. So now you've got a lot of data. Try to feed that into a deep learning network. It's hard. It's just too many pixels, right? Too much stuff. So what we did was we trained a neural net on these movies. This movie is like 50K, right? Because it's an MPEG movie. And so you basically train a neural network to detect this ball that isn't contracting, and it did a great job. Yeah, it did a great job. It just became the human observer watching the movie and says, oh yeah, this movie, that thing's wrong, right? And so
But have to be like omnisciently aware of every voxel.
you don't have to have the voxels, you just have to have a rendering that shows the abnormality directly. And it's pretty cool. It worked great. And we'll try and sort of juice that thing up so that not only tells you if it's abnormal, it'll tell you where the abnormality is and how abnormal it is and stuff like that. But that's the next step. Okay, so I'm going to quit there because we've run out of time. Any questions from folks online? Just shout it out if you have a question. If not, we'll continue with some CT applications next Monday briefly, and then move into MR after that. Okay. All right. See you next week.